Well, the density of medical centers and hospitals in the New York tri-state area is enormous. And, you know, we're so deep into it now that New Yorkers love competition, but all boundaries have been put aside. Everyone is trying to help each other because the surge is skyrocketing at an exponential clip. So the governor, the mayor, they may fight every day, but they're looking out at the bigger picture, as is the health commissioner. And yeah, we're all helping each other. At New York Presbyterian, we have 12 hospitals, and every decree, every rule, every policy is with all 12 in mind. And so one of the things I'm sure will come up is, do children's hospitals take in adults? And what we've decided at New York Presbyterian, which is a good thing, is that all pediatrics is closing everywhere except Morgan Stanley. And so we're funneling in all of the children who are in our system but at other places to make room for their adult surge, even though that's filling us up. At the same time, the adult facility is borrowing our pediatric providers. So, you know, we're kind of working against each other, but that's settling out. But that's how we're doing it. We're going to fill the children's hospital with children and empty beds in the neighboring facilities that are part of our system. So yeah, that's one way that we're going.
Yeah, and I love that approach. We've begun to do some of that here as well, of concentrating the kids and the non-COVID kids that need medical care, whether it's babies or cancer or trauma, in one building.
Yep. And
hopefully freeing up everybody else. So it's a good approach. I like it. Adam, you guys have any comments on the resource flexing issue?
We, I mean, not too much. As being freestanding, like some of your hospitals, and being pretty far away, we haven't, just looking at the questions that you have sent over, we haven't had any discussions about loaning equipment. The PPE issue, most of it has gone to the adult hospitals. We did just have a donation of 18,000 masks, but my understanding is that covers us for about a week in normal operations. So there has been some sharing of that type of resource to all of the hospitals in the area. We have been talking about what Dr. Stiliano said, shifting patients from the adult environments, especially Harborview, over to children's. But also maybe increasing our age limits so that we can cover some more of the, you know, older up to the, 20s type patients who may develop COVID in our ICUs. And then the last thing that I would comment on is there has been some escalation of ideas to try to share resources across all the different hospitals, which comes down to credentialing. We have a lot of issues with unions, especially nursing unions in the state, and trying to create some expedition of credentialing between nurses and physicians so they can cross-cover different institutions across the city. But that hasn't come to fruition. It's just in the discussion phases right now.
Those are very important points, Adam. And we've done the same with trauma, where we bounced the age up. Congenital heart surgery in adults, we're going to do those here. And obstetrical ICU needs for the moms, we're going to keep them here too. So we're trying to do everything that we can, because our adult hospital is just bursting in ventilated patients. One of the things that I sent in by attachment is something on scope of practice and liability, because we can move practitioners across 12 different hospitals now. And I think those are very, very important points to sort out as fast as you guys can.
Do you traditionally have an L&D unit attached to your children's hospital, or is that a new?
Yeah, it's a women and children's hospital.
Okay.
So they're here.
Okay. Samir, how about Michigan? Any sharing issues?
So at a statewide level, all of the critical care intensivists, adults, pediatric, everyone, is now part of a network called MCCCN, and that's the website name, mcccn.org, where all of our resources are now pooled there. We're kind of somewhat aware of like what is happening at a statewide level as to which hospital beds are being used up and where people need to get diverted. It's not completely coordinated, but at least the educational information and resources are being shared. From an adult pediatric unit, we stopped doing elective surgeries for a couple of weeks now, and we've transitioned a lot of our patients outpatient, and that's for all of the places that we cover. So as many of you know, our model involves covering our outlying facilities as pediatric surgeons, and we've stopped doing surgeries at every one of those institutions. That way we can preserve PPE, we can preserve intubations, ventilators, hospital beds, so on and so forth. Our regional ICU is actually located at Mott Hospital, and that's been filled. And so we've definitely hit capacity there, and now we're using up regular ICU beds. So it's pretty, we're definitely in the surge right now. We've been preparing for it in terms of our practitioners using Lombardi model by decreasing the number of people in the hospital. Because we've reduced our elective surgeries, there's less of us that need to be there. And so there's hopefully less exposure for all of us. And then we've changed our system so that there's one person on call as the surgeon, one person on for the ICU, so that on any given day, there's less people here in the hospital. We're also giving up our names for deployment to the adult side as needed for both surgery as well as ICU care. And so if we're needed on the adult side, we would then help provide care for the adults as well. I don't know, what else did you want to know on there?
That's nice. So you've created a peds surgery, peds intensivist pool of providers that are willing to cover. Does your ICU, because you're the critical care guru, does your ICU have any tele ICU connections to the surrounding hospitals?
No, but there's a weekly Zoom phone call like this in terms of discussion of, so like we had one earlier this week around, management strategies and what's being done and so forth. And so that everyone has the same expectations in terms of who would be provided ECMO, ventilator management strategies, so forth. And so it's with all the critical care intensivists in Michigan, not just at Mott or not just at U of M, but like all of Michigan. And so it was just, the basics were, discussed in terms of this is how we would manage. These are criteria that we could potentially use, so that we stay consistent within the whole state.
Got it.
And we've been in shutdown for a little while in terms of shelter in place and so forth.
Great. Mike, do you want to comment?
Sure. So Rainbow is part of a large healthcare system. So we've got 15 hospitals, 30,000 employees, 3,000 physicians. So they've really tried to leverage that network. And what they've done is for all the physicians, we had to fill out a basic survey of what our skills were, what our board exams were, what our skills are as far as intubation, central lines, et cetera, and then create a large database of who is competent in critical care and ICU skills. And that's how they're starting to triage and be able to resource out the healthcare system. What they've actually tried to do is designate 2 of the community hospitals, east and west, as those are going to be the COVID hospitals, trying to preserve some capacity at the main academic medical center for, the emergent AAAs, the emergent cardiac cases, the transplants, et cetera. With the sickest of the sick COVID, they actually have deployable shock teams that will go out to these community hospitals, help stabilize them, help put them on ECMO if need be, and then bring them into the main medical center. So as far as the pediatric capabilities, and kind of somewhat positioned here as peds, surgical critical care, we're just in this pool of folks that are around and available to back up